Welcome. I am Sarah Weatherson, she, her, white woman with gray and brown hair and glasses, and I'm the lead staff for the Medicaid Advisory Committee, or the MAC. This is the MAC's public meeting for February 2026 to help fulfill its federal and state mandates to advise both the Oregon Health Authority, or OHA, and the Oregon Department of Human Services, or ODHS, on how to run Oregon's Medicaid program. I'm going to share a few logistical announcements before we get started. We're going to ask folks to mute yourself if you're not speaking. If you're joining by phone, please mute yourself if you're not speaking, and please avoid putting the meeting on hold. If you have to leave, it's better to hang up and rejoin the meeting. And MAC members, we'll ask you to use your raise hand button if you have a comment or a question, or put a note in the chat to let us know you want to speak. So the Medicaid Advisory Committee has built in time for discussion after each presentation. MAC members will speak first. When we've exhausted questions from MAC members, if time remains for the agenda item, we'll take general questions. And we have also scheduled 10 minutes for public comment at 11 a.m. So we do have ASL and Spanish language interpretation available for today's meeting. You can pin the ASL interpreter's video by clicking on the More button next to their name. And there's also a button for interpretation, which is where you'll find the Spanish language interpretation at the bottom of your Zoom screens. I'll also note that whether you are listening in Spanish or in English, you'll need to pick a channel so that you can hear if there's any translation in either language. All right. So I am now going to hand it off to MAC co-chair Caroline Barrett, Dr. Caroline Barrett, to take us through our meeting. And with that, Dr. Barrett.
Good morning. Welcome, committee members and members of the public. So we're going to start with roll call and reminder to members that to please declare if they have any conflicts of interest. And so to start our roll call, Dr. Asma Ahmed.
I'm here.
Director Emma Sando.
I'm here.
Hillary Prochot. Okay, I'll circle back. Jerry Weeks. I know you're here, Jerry, but I didn't hear you.
I'm here.
Hello.
Okay, good.
Kaya Adams.
Present.
Kelly DeVore.
Here.
Lydia Dennehy.
Here.
Shannon Buck. Stacy Shaw.
Present.
Peter Starkey. And I see in the chat that Hillary is here. Circling back, Shannon, are you here? And Peter? Sarah, do we have a quorum?
Sorry, having trouble getting off mute. Yes, indeed, we do have a quorum. Thank you.
Thank you. Committee members, last week you received draft minutes from our most recent regular meeting to review, which was last month in January. Please take a moment to review the minutes for any errors or omissions. Do any committee members have concerns about the minutes? If there are no revisions, I also want to call attention to the consent agenda, which you have also received prior to this meeting for review. Do I have a motion to approve the January meeting minutes and to acknowledge our consent agenda?
This is Asma. I so move.
Thank you, Asma. Do I have a second?
This is Lydia. I second.
Thank you, Lydia. Any objections? Any abstentions? The motion carries. And now I'll pass off to Director Emma Sando for our Medicaid Director update.
Thank you so much. I am happy to be here today to provide our February update. I wanted to acknowledge a couple things that have happened this month. And first and foremost, as of February 1st, we went through the transition in Lane County between Pacific Source, who made the decision to leave that region back in the fall, and Trillium, who was in that region, who took up new members. The team continues to monitor to ensure that patients have and members have access to services and a transition between the services that they had been receiving and their new services. As part of the process, people have 60 days to continue to see providers that were in the Pacific Source network. For example, if somebody had an appointment that they scheduled 6 months in advance, that appointment would be maintained. And then and with people that are dually enrolled in Medicare and Medicaid, that timeline is 90 days. And so we are very much continuing to monitor that, learn any lessons to ensure that any future transitions in the state are we are taking into account any learnings and lessons from this experience. But we have been able to resolve a lot of concerns very rapidly, and have been really grateful for our partners at Pacific Source and Trillium for all their hard work on that transition. In the news as well is a lot of discussion related to the provider networks and provider contracting, as that continues to be a very focused area of Medicaid policy at this time, due in part to CCO contracting changes and things that have occurred between providers and CCOs. And I just want to reiterate something I believe I mentioned at an earlier meeting, but want to ensure that you all have visibility into the way in which contracts between the state and CCO's work is that we monitor for what is known as network adequacy to ensure that members have the ability to, based on a variety of different metrics, access services in the network that they are served. And that is a complex process that we review significant changes to the care network to ensure that members maintain those contractual requirements. And the team is very busy ensuring that the data that we do receive around our networks are meeting those contract requirements. And always happy to have a more in-depth conversation about what network adequacy is and isn't, and how that relates to this process. Finally, we have been extremely well, not finally, I've got one more after that. Apologies. We have been extremely busy with the legislative short session. It is not over yet, but we have been responding to a variety of questions related to bills and analysis related to a variety of bills that are going through the legislative process in this extremely rapid timeline for short session, which ends somehow in about a week and a half. And it certainly feels more of a sprint than the long session marathon. I would provide you a summary of some of the high level changes that the legislature has made in as part of this legislative session, but since it is not quite finished, I am going to leave that for our March update to give a sense of some of the strategies and tactics that or strategies and bills we've seen coming out of this legislative session. Now finally, I have continued to update you all on our work requirement implementation process and the implementation of the various provisions related to HR 1. I don't know how Jessica Diaz seems to be able to drop this link whenever I mention it so quickly, but I'm going to call on her to. Oh, and thank you, Sarah, for reminding me. April meeting, not March meeting. I apologize. I forgot about the spring break and the fact that we're going to be meeting next in April. But we have continued to update our federal response page. And most notably, I want to direct your attention to some of the updates that we've recently made regarding data and data privacy, and ensure that you all have that resource and share that resource. We have those materials available in multiple languages, and want to make sure that those are getting out into the community, with regard to some of the recent decisions at the federal level and how they affect Oregon. The other HR 1 health, also known as the One Big Beautiful Bill Act, implementation efforts. We have been working on developing plans for additional community outreach related to the implementation, but are working to ensure that we are prepared for when it is the appropriate time for members to take action, or community partners to take action, that we are engaging with our community partners at that appropriate time so that there's reduced confusion. That's really one of our main goals. And so we are very much know that there's a lot of eagerness to get people to act, but would want to just note that we are being very mindful around trying to reduce confusion in terms of the engagement plan, and have been making a lot of efforts in that planning, and also something that we can bring back at a later point if the committee is interested. And I think I kept within my time this time.
Thank you, Emma. There's time for probably one question from committee members if anyone has a question for Emma. Jerry?
Good to see you. I've been attending some OCHN meetings about workforce documentation and redetermination, and I'm wondering if the state's working with them, because they're getting ready to roll out some technology hopefully soon, so that we can all get familiarized and use it at the service delivery end, because we see the patients, and I think we're instrumental during the big redetermination and keeping Oregonians covered. So I'm just wondering if there's some collaboration between the state and OCHN to make sure that we can collect it, but how it gets to you, I don't know. So just wondering about that. Thank you.
Yes. Thank you, Jerry. So great question. And so yes, I would say yes, we are aware of those activities, and I will note that for folks that might not know, one of the exceptions to the work requirements is whether somebody has the medical meets some medical criteria to not work. And that criteria is what is known as medically frail. There is a lot of unknowns about what the federal government will allow states to do, and in order to prove that somebody is medically frail. And we are in constant communication with our federal partners to try to get a better understanding of the uh, the potential policy direction that the federal government is going in, so that we can adjust our policies and processes accordingly. But we are very much taking the stand that more information and any ways in which we can ensure that people who may have disabilities or other reasons medically why they aren't able to work are not subject to the work requirement, and are very interested in being as uh, uh, member focused and getting as much information as we can. And so that is a key tenet of the work that we're doing. It does sound at this point as though the federal government is largely relying on claims information, and so we want to make sure that there's hopefully some other tools, because somebody, for example, may be born with a certain disability that doesn't require regular visits related to that disability or that impairment, and so they shouldn't have to. We shouldn't have to have a claim on a regular basis in our systems in order to prove that that person is continues to have that permanent reason for not being able to work.
Thank you. Well, we will move on to the Beneficiary Advisory Council update. Thank you, Emma, for that thorough update. We appreciate that. So moving on to the Beneficiary Advisory Council update, we will have Lydia Dennehy, a member of both the MAC and BAC, to inform us of the work the BAC has been doing since our last MAC meeting. Thank you, Lydia.
Great, good morning. I'm assuming somebody else is sharing slides or, okay, sorry. So we had a robust roundtable as usual. So a lot of thought about transportation providers only picking up from somebody's place of residence and dropping off only at residence, which penalizes people who work or who have kids who are at school and wanting to drop them off at school or pick them up from school. So it's a hardship for parents and workers. We had somebody say there's an uptick in racism that impedes access to care for the Hispanic community, that care conditions are degrading, and that the community is afraid and feels unsafe when they go to seek care, and some of them are not seeking care. Re-enrollments for children who received OHP under an income waiver could be simplified to ask about changes in income as opposed to going through the whole process. Getting referrals to specialists outside of Portland are difficult, and it's unclear when there are specialists in the area. So that network transparency. And that appointment time is too brief and you must get a second appointment. And this is particularly true if there's medical complexity or if there's translation involved. Next slide. So we got an update about House Resolution 1. We got some background information and the state of the state. And then the back advice regarding communications to OHP members suggested that radio was an opportunity that infographics were really helpful in communicating, that being really clear about timelines, because that reduces anxiety, and that we might partner with the Bureau of Labor and Industries and others to reach workers, unions, other other places that people get information to workers. And we looked at future topics, and ensuring access and protecting eligibility was our highest priority. Next slide, please. So we worked on working with the MAC and what we'll provide advice on, when and how. We had some people say that they needed more time to process and think about some of the things that we saw. So we will be getting back to you, but we didn't have a fully realized plan. And we'll work on membership and onboarding and selecting group chairs soon. Next slide. So in that defining the BAC and MAC relationship, we looked at this infographic. So developing new pathways for back to weigh in, and then existing MAC and OHA processes to weigh in on. We did not have enough time to give formal comments on the MAC report, and so we would like to request that the MAC hold off until the April meeting so that we have time to vote. Let's see, time to give input before we vote. So there's a report that we're going to vote on today. We were supposed to, but BAC is asking to hold off until April. Next slide. Let's see. So the MAC rubric for comment, that was the too little time for discussion. So that's the report that we were hoping to hold off on. And we had a suggestion that we add a question about asking the BAC, into sliding that into the rubric. Okay. And then after we finalize our plan for how to work with the MAC, we'll work on membership and onboarding and that selection of group chairs. We have 2 nominees from the BAC to the MAC that are at the governor's office for consideration. So they should be ready to go in April if they are selected, and we certainly hope that they are. Next slide, please. That's that's my report, and if you have any questions, I'm happy to take them.
Thank you, Lydia. Appreciate the request for the MAC to consider waiting to adopt the policy rubric that we will be discussing later this morning. We have time for just one question if anyone has a question for Lydia. I did have a question about the that I might save for the discussion around the policy rubric when we are on that topic. So I will circle back to that then of what what specifically you're hoping for the BAC or the policy rubric to include about asking the BAC in that rubric. So we can circle back to that discussion in the policy rubric part. So thank you, Lydia. Moving on to the Oregon Health Policy Board update. We have a brief update about the work of the OHPB. And here to present is Peter Starkey. Thank you for being here, Peter.
I'm so sorry. Peter isn't here today, so I didn't anticipate that, and so I think we will move on. I do want to take a minute while since to go through. I'm going to read a lot of the comments that we have in the chat, so that the interpreters can um catch us up for the folks who need the interpretation. So there's a question about how people indicate they want to give public comment during the public comment section, and that the response to that is for them to send a private message to either Tom Cogswell or Sarah Weatherson. We have some logistical comments from a couple of members. And we've posted the federal changes on the OHA website. That is the OHA website that lists out federal changes. We've posted that in English and in Spanish. There's a question about whether the reference to OCHIN was, if somebody could clear up what that reference to OCHIN was. And OCHIN is an organization that provides EPIC, electronic health record. It is an electronic health record to community health centers in Oregon and around the country. And then we have a couple of chats that are in Spanish. So I'm gonna ask the interpreters to help me out with those.
Do we need to pause for a minute to allow them to catch up?
Probably.
Okay, let me know when we should commence again.
Maria's comment, sorry, this is Rosie interpreter. Maria's comment was just asking for the chat to be interpret for her. And we have Erika Zamora. Is it true the OHP is going to provide information to people they have under I don't know. Can we have Erica maybe? Let me ask Erica if she come up, because I don't understand the last part of her comment. 1 second.
Está preguntando de que
I
qué
was
tan cierto es
asking
que
if, is
OHP
it true
va a
the
compartir la información de
OHP
las
is going
personas
to share
que están aseguradas
information
con él,
for
que son
those that
migrantes?
have, the medical coverage and they're immigrants?
Hey everyone, my name is Jessica Diaz, and I also work for the Oregon Health Authority. I'm going to drop into the chat the direct links to information about federal data sharing in English and in Spanish, because I think this question is in reference to some changes federally that are, there are some fairly complex aspects of it that we've worked really hard to put into an FAQ and a what you need to know document. And I don't know how much time we have, so I'm not going to rush into that topic, but I think that is, I hope, helpful to Erica and anyone else who has questions about what is happening in relation with Medicaid data and immigration on the federal level. So I'm going to go search for that and get it to you right now.
Thank you, Jessica. And it is time for us to move on to our next topic. Sarah, is it okay if we move on?
Yes, thanks. I think we're caught up.
Okay. So we are going to move on to presentation of the draft policy rubric that myself and Jerry worked on a subcommittee to develop. So I'm going to hand it over to Jerry to present what we discussed. Thank you, Jerry.
Hey, all right. The next slide, please. Back in April 2025, the MAC co-chairs identified a need for a policy rubric. And then completed goal setting was the first process. And then we decided we needed to form a subcommittee, which we did, which Caroline mentioned. It was herself, me, and Sarah helped facilitate that. Thank you, Sarah. And we've met twice. We've had lots of discussions about how the changes at the federal level might impact the work that the state wants to accomplish. And we don't have all the answers to some of that yet. We shared the draft with the Beneficiary Advisory Council, which Lydia mentioned. Thank you, Lydia. And it's a very thoughtful list of items for us to consider. And I think we all agree that we needed another month in order to take a look at that in more detail. Can we have the next slide, please? And the rubric included standardizing the advising process, focusing on the MAC priorities, and making the MAC values transparent. And they're largely similar, but they have some differences. So next slide. And we had a twofold purpose in our policy questions: to express values of the MAC to decision makers, and to help MAC members evaluate proposed policies and or changes. And that's based on SMARTY goals, which I have what that means somewhere in my packet here. I usually know that off the top of my head, and I can't remember what it is. Anyway, Sarah, do you have that somewhere?
I have it somewhere and I'm going to drop it in the chat.
Okay, thank you.
They are the strategic, measurable, ambitious, realistic, time-bound, inclusive, and equitable goals is what my quick Google is showing us that
A
it
usually
stands
for
for.
like achievable.
Yes, usually it's achievable. This is coming up with ambitious. Achievable is usually what I am used to as well. So I'm not sure what I just came up with here.
You need ambition to make the achievements.
There we go. There we go. Appreciate it, Kaya.
Thank you. And then the last thing we discussed at length was questions about accountability and how that impacts all of us. How do we have accountability built into the policies and procedures and work that we want to carry out? So next slide, please. So I think we're going to open it up for discussion.
Just to add to it, we had talked about this as co-chairs last spring, thinking about knowing with some of the changes coming at the federal level of that we might be approached by OHA with, and we have been approached by OHA even prior to changes at the federal level of weighing in on policy and how and proposed changes, and how do we have a consistent way of making decisions of whether or not we are going to recommend for or against a proposed policy change, and when and to also provide this information, these sets of values to the OHA when to consider when they are making policy changes and proposed programs. And this helps delineate what some of our values and priorities are based on the goals that we came up with on the SMARTY goals at our retreat last May, I believe it was. So that's what they are based on. And the BAC came up with a very thorough list of additional questions And this, and I know, so we have to consider, and Lydia had asked for us to for them to have time to make a formal recommendation of whether or not we adopt the rubric before we as a committee vote on it. Lydia, I was hoping to ask you to clarify, can you clarify what you were saying in your presentation about adding a question about asking the back?
I'm going to take that question because that was
Okay.
actually a staff recommendation
Oh, okay.
that came
Thank you.
after the meeting. So we in a discussion realized that there wasn't, although we had mentioned like how we would use the rubric to demonstrate why we might come to a decision that was different from OHPB or the back. We did not mention actually going to the back and asking for their feedback or otherwise incorporating their feedback. So wanted to just call that out as a question among the other questions.
Thank you. Lydia, were there other comments from the back discussion that you were hoping to raise today, or other members of the MAC? Were there questions about the process or thoughts that you think should be raised as part of this proposed rubric?
From the back, we just mostly had discussion about whether we had enough time to look at the rubric before the meeting. So it was circular, and no, we didn't come up with anything aside from a request.
That is
Thank you
very
for
fair.
input.
Having time to think about it is critical. So I appreciate that. And your member who made the thorough list of questions was very thoughtful. And I look forward to us reconsidering how we can include some or all or parts of that in the rubric. Other members of the MAC, thoughts or questions?
Caroline, this is Kelly. I have a question about how the rubric would be used and whether it would be individual members going through and answering those questions, or whether it would be a collective conversation. And maybe we don't know that yet until it's put into place, but curious about the process for use.
I think that is not entirely known at this point. I think the thought, and please chime in, Jerry and Sarah, but the providing the list of the information to OHA to help them in their consideration of proposed programs and policy, and then potentially subcommittees discussing the policy. And then what we had talked about as a group, as a subcommittee for this, was that potentially it would be brought to a whole MAC meeting and voted and scored and discussed. But generally the whole MAC committee would be making a decision together, but possibly some subcommittee work involved as well. Did I reflect that appropriately, Jerry and Sarah?
Yeah, I think that's right.
Yes, I agree.
Thank you. Other questions, concerns?
Caroline, so the request is, are there any questions about the process of the rubric or the rubric itself?
I'm sorry, can you say that again?
So is this space for questions about the rubric itself? or about the process and what else needs to be considered?
Whatever question you have, we can try to address it.
Okay. Well, I'm new, so I was trying to figure out what the space is. I had a couple questions based on my reading of this document, and my apologies that I have not been part of the conversation. So if any of the questions are, we already addressed this, I apologize in advance for that. In the rubric for rubric questions, the document that has questions based on MAC SMARTY goals for 2025 to 2027. The first one is retain health insurance coverage in Oregon at the state's 97% rate. Considering that the MAC's focus is on the Medicaid population, I'm curious, like, how was it looked at? Like, does it advantage anyone or exclude or include anyone in the way that's written? It's just a question.
Sarah, you wrote that language. Can you speak to what you drafted that on? I know we were focused on the goal of maintaining as much coverage as possible.
Yeah, thanks for that. I think that our thinking in writing the goal that way was to recognize that while we don't have certainly policy, it's outside of our scope to advise the state on policy outside of Medicaid. We also recognize that while the federal, especially what's coming down from the federal level, we may not have any way to change that, address that directly. So we thought about, back it up. We thought about first not having the rates of Medicaid coverage change. But we realized that might have to change, but the state has other levers to use to ensure that people remain insured in one way or another. And so we wrote the SMARTY goal to look at overall insurance rates to take that into account. While it might be out of the state's control to retain Medicaid coverage, the state may have other levers to ensure that people stay covered. Does that make sense? And does that address your question more importantly?
It does. Okay, I will defer to the wisdom of the group. For me, I'm just wondering, like, does MAC, like you said, MAC focuses on the Medicaid population. So I'm like, okay, well, maybe we just need to play it out in action to see how that works.
The thought also with these is that every biennium, these are updated with based on the goals that are made by the MAC, because we update our goals every biennium. And so then the policy rubric goals would be updated every biennium. So this policy rubric would not be in perpetuity, but would be amended every 2 years.
Understood. So that does bring me to my next question. Is that the thought on writing the second goal? Because it specifically references the 1115 waiver. It was a thought that 1115 waiver will expire next year. So that, or in 2027. So then no, you said biennium, right?
So these are based on the MAC goals for 2025 to 2027. So that is what these goals are based on, the work group that we had at the MAC retreat in spring 2025.
Mm-hmm.
And that the 1115 waiver is set to expire, but we don't know if it will be renewed or not. And so we're operating under the information that we currently have.
Right, so the way the second one is written, that guidance will expire when the 1115, if something does happen to the 1115 waiver. So based on what I'm hearing, that sounds intentional. So that the guidance would need to be re-looked at that expiration date.
Yes,
Okay.
yes. These are, the intention of these is not that they will never be changed, but that they will be updated.
Gotcha.
And also want to reflect that this is a first time we are trying this. And so this is not going, I part of one of my roles is doing quality improvement work, and we try things, we see how it works, and then amend and adjust and retry things. So I have that as part of my modus of operating. So I fully acknowledge that some of these questions we might find don't work as well as we're hoping, and we amend, is how I see it.
I have more questions. Happy to hold or ask.
I'm looking, we still have time. Are there other members who have questions? Okay, then Asma, welcome more questions. And Jerry, feel free to chime in and answer as well.
I'm gonna just check in about the chat. So we have a number of chats from the public asking about and making some recommendations about the rubric. I'm gonna suggest that we hold on, we treat those like public testimony, but for the sake of the folks who need this in Spanish, the comments are that the rubric waters down equity and parity. This should be weighted, asking about how one attends back meetings. And so I've dropped the information about beneficiary advisory council meetings in the chat, asking, pointing out that the back meets in 2 months, and that is true, and they meet right before the right before the Medicaid Advisory Council meets. So asking whether the public can fill in the rubrics to send to the subcommittee and who it should be sent to. I would say we would treat that like public testimony. So if you want to send filled in rubrics to us, you can send it to Mac Info. I will put the email in the chat. And we also again have a request to amend to add P, I guess that's for parity, to the Smarty goals. I also and Victor's probably seen this, just a request or pointing out that some of the interpretation is cutting off, and folks in the Spanish channel are hearing English.
Okay, thank you, Sarah. Asma?
Caroline, based on what you shared about process improvement, are there other things that Mac would consider a rubric update for? Or is it like, hey, we'll review this every couple of years?
Can you be more specific about what you're referring to?
Sure. Like for if the 1115 waiver, if does expire in next year, so then that would be, that section either would need to go away or the rubric would need to be updated. So are there other things that would reopen or change the cadence of when the rubric gets updated.
I think we would have to take that on a case-by-case
Okay.
basis.
I think Oregon's Medicaid program is built on the 1115 waiver, so that would
Correct.
be a huge structural change. So we would have to come back and revisit the rubric.
That's fair. One last question on that third one, access to care. Workforce expansion, phenomenal goal. I'm curious why it was focused on workforce shortages alone, access to care. That's one contributor, but not the only contributor for challenges in access to care.
This again came out of the work group from last May of work goals for the MAC committee that was specifically thinking about network adequacy, and there was a focus on workforce expansion as in a way of trying to help improve network adequacy, and the focus was around workforce expansion.
So the thought is at this time, we'll keep it to workforce, and then maybe in the future think about need or want to expand beyond that.
Yes, we were really focusing on what the committee had focused on at the goal setting
Gotcha.
committee in last May. And
Got
that had been focused on workforce expansion at that time.
Understood. Thank you.
Had that narrow focus at that time. And we have had presentations of what OHA has been. I can't remember which meeting it was at. Sarah, if you remember, please remind me, but we had a presentation from OHA, I believe it was OHA, about scholarship opportunities, retention programs throughout the state, and the work that is being done for workforce expansion in Oregon and workforce retention in Oregon.
Gotcha. Thank you.
Yeah.
All that context I was missing. Appreciate it.
So these are while these can seem out of place, they are directly tied to the work group that was last May and came directly from that retreat where we focused on where did we want the MAC efforts to be focused.
Understood. Thank you.
Of course. And as I said, the intent is that they would be updated as work goals for the MAC change, or if there are significant other changes such as expiration of the 1115 waiver or other unanticipated changes that would significantly impact these proposed rubric. I appreciate the thorough questions and engagement. What other questions or comments or concerns do members of the committee have?
This is Lydia. Guys, I think people were maybe thinking of like a scoring rubric rather than all of the things that I think they were thinking that we were commenting on a framework rather than the things that we had already decided to work on being put into the framework. And so I think that might be where some of the confusion is about why these specific goals. And it's those are past goals. I mean, that we're already in 2026. So those are past goals that have been put into the framework. Other goals will come in and shift that framework when they when they arise.
Thank you. Kelly?
Yeah, thanks, Caroline. I was just going to suggest, I know the agenda says possible action or possible vote, given the questions and the discussion and the expression from the back about wanting more time to understand. It doesn't sound, I was just going to offer, I'm not sure if the group is ready to approve the rubric unless there's a timeline constraint requiring it to be done today.
There is no timeline constraints, and I think it would be personally, I think it would be very appropriate to allow and important to allow the back time to really reflect on this as well. Do others agree or disagree?
I agree.
This is Kaya and I agree.
This is Lydia. I agree as well.
Ozma's thumbings up. Fantastic. So let us reconvene after the back has had more time to review, and we can reconvene on this topic. So I appreciate the robust discussion, and we will move on to our next topic. I know we're a couple minutes early. Erica, are you here?
Hey, yes, I'm here.
Wonderful. So we are going to move over to Form A process with Multi-Care Intercommunity Health Network. And this is our this is a summary of a proposed transaction involving Intercommunity Health Network, ACCO, and Multi-Care Health System. And presenting is Erica Kosher, Senior Policy Advisory of the Healthcare Market Oversight Program from OHA. Thank you for being here today.
Great. Thank you for having me and giving us this time to speak to the committee. I will introduce myself first. Erica Kosher. I'm from OHA, and I lead what is called the CCO Form A review process. If you get to go to the next slide, please. A little bit about what that is. So OHA is required by law to review certain transactions that involve coordinated care organizations, such as mergers or acquisitions, essentially when there's a change in control of who controls the CCO, to make sure that they promote the interests of Oregon Health Plan members and all Oregonians. So that is referred to as the CCO Form A review process. When there's a proposed transaction, we look at several factors to evaluate the impact of that transaction on a CCO and its members. And then OHA has the authority to either approve the transaction, approve it with conditions, meaning place specific requirements on the entities for how the transaction is structured or commitments that they would need to make, or deny the transaction. Hearing that it's difficult to hear. Does this help at all? Am I clear? Okay, great. So
Yes.
switch the microphone input. Great. So, and the Form A, this review process started, legislation was passed in 2019 that created it, and essentially mirrors a very similar process that DCBS conducts when there is a domestic insurer undergoing a transaction. Next slide. So I'm here today because the CCO Form A review program is currently reviewing a proposed transaction that involves Samaritan's Intercommunity Health Network, CCO, which I'll refer to as IHN for short, and Multi-Care Health System, which is a large health system based out of Washington State. And so we're here to provide information to the committee about the proposed transaction, about how the CCO Form A review process works, and how Members of the committee and the public can provide feedback to the CCO Form A program or raise questions that you'd like us to consider in conducting our review. By statute, we are required to seek feedback from the Medicaid Advisory Committee. Next slide. I'll go over some of the factors that the Form A review process looks at when evaluating a proposed transaction. There are a number of items. One of those is how will the transaction impact the CCO's financial stability, its ability to continue offering high value, high quality services that do not create any access barriers and that keep provide those services under the state cost growth limits. Also look at if the transaction would impact the CCO's ability to meet its various state and federal requirements, legal and contractual requirements, how it may impact the CCO's relationships with their local community, serve diverse populations, underserved populations, support social determinants of health, and overall advance OHPD's policy goals. Next slide. As I said, OHA has the authority to refuse to approve a transaction on any number of grounds. I'll go over them at a high level. If the transaction, if we find it is contrary to law, if it is unfair to CCO members, if it would jeopardize the financial stability of the CCO, if we found there may be plans post-transaction to sell, liquidate, or merge the CCO with another entity, if there were concerns about the competence and experience of the new entity that would be controlling the CCO, or concerns about, I guess, the CCO's ability to address the needs of its community. Next slide. And again, at a high level, you can also look at would it substantially reduce the service to CCO members, access to care, the quality of care, the connection to the community, a number of grounds that if we find concerns, OHA has authority to deny a transaction. Next slide. In terms of how we conduct our review, this process can take 6 months or longer. There isn't a specified required time frame. This filing was made in January, and so once we receive a Form A filing from the entities about a proposed transaction, we will review that. We will often send additional information requests to the entities to get more information, which we are doing here. We engage with subject matter experts, outside advisors, engage the public for input, and we also coordinate with any other regulatory review streams that have been triggered by a proposed transaction, which I'll speak a little bit about on the next slide. And so once all of that process carries out and we have the information we need, then OHA issues its decision. Next slide. Like I mentioned, sometimes these healthcare transactions can trigger other regulatory review processes in tandem with the CCO Form A review. If a transaction also involves a domestic insurer, DCBS will conduct a review of that as well. Here, Samaritan's also has a commercial health plan, and so DCBS is conducting a concurrent review. A transaction also may require review by OHA's Healthcare Market Oversight Program, which reviews transactions involving a broad range of healthcare entities, including CCOs and domestic insurers. To tell you a bit more about the proposed transaction here, I'll start with a short description of the entities. Go to the next slide. Next one. Inter-Community Health Network, CCO, you all may be familiar with them. They are nonprofit, currently solely owned and controlled by Samaritan Health Services, governed by a local board of 12 elected directors. And IHN serves Oregon Health Plan members in Benton, Lincoln, and Lynn counties. Next slide. MultiCare is a large nonprofit health system based in Tacoma, Washington. They operate 13 hospitals in Washington state and more than 300 primary and specialty care clinics. They serve more than 2.1 million patients annually. A very small percentage of that are Oregonians, about 5,400 that kind of cross into the MultiCare system across the border. And they do not currently operate any health insurance plans. Next slide. And one more. So the proposed transaction here is Samaritan and MultiCare have entered into an affiliation agreement. And through this, MultiCare would become the sole corporate member of Samaritan, which would bring Samaritan Health System and IHN under MultiCare's control. MultiCare has stated they would become directly responsible for supporting IHN financially. And they've stated in their filing to us that they are committing to providing IHN with any necessary capital infusions and funding any operating losses. This transaction does also involve Samaritan's broader health system. That's not the focus of the CCO Form A review, but MultiCare has also separately committed to making a 10-year, $700 million capital commitment to Samaritan's health system, which they've said will be used for infrastructure improvements, expanding services, recruiting more providers, and addressing other community needs. And that is something that will be focused on by the other regulatory review stream, by the Healthcare Market Oversight Review. Next slide. In terms of why the entities have said they are doing this transaction, according to the entities and what they have told OHA, Samaritan stated that they determined that they could not continue to meet the healthcare needs of its community alone, and they undertook a comprehensive process to identify a potential partner, ultimately identifying MultiCare. MultiCare has stated the transaction is needed to provide IHN with capital, infrastructure, and expertise to improve access to services. And Samaritan has said that without the transaction, there is a risk they may have to sell, reduce, or end its CCO and commercial health plan offerings or other healthcare services. Next slide. In terms of how this may impact IHN post-transaction, MultiCare has stated that they will, for a minimum of the next 3 years, continue operating IHN in Benton, Lincoln, and Lynn counties, as well as the dual eligibles plan they offer, subject to any OHA procurement process that may happen during that time. They've stated there are no planned changes to the composition of the IHN board. They would plan to leave that in place. If there are any unexpected circumstances or situations beyond the entity's control that would require termination of the CCO, the affiliation requires approval from both MultiCare and Samaritan's boards before that would happen. The entities have stated that they intend for this to be a permanent affiliation. MultiCare says they will not transfer or sell all or substantially all of Samaritan's assets for a minimum of 7 years without approval of the Samaritan board. With respect to the CCO specifically, MultiCare has stated they do not have any plans to declare dividend, liquidate IHN, or sell IHN's assets to another organization. Next slide. In terms of some changes, kind of more day-to-day changes, they have stated that IHN leadership would report through MultiCare's existing population health infrastructure. MultiCare manages over 400,000 patients in risk-based contracts and has a population health enterprise, and so it would fall under that that part of their business. Additionally, currently Samaritan Health Services provides IHN with management and administrative services. That is expected to shift to MultiCare. They stated they do not have plans to make any other material changes to the business operations, corporate structure, or management. They do not anticipate changes to IHN's services or service area, or plan to move the offices of IHN's operations. Next slide. And so in terms of OHA's role, we are reviewing this proposed transaction under the statutory criteria, looking at the factors that I discussed previously, and focusing on how this will impact IHN and the community it serves. We'll be looking at information that has been submitted by the entities. We are requesting additional information from the entities to answer some questions that we have. And we also will be considering public input and any feedback that the committee may have on this transaction. Next slide. And like I said, this transaction is also subject to 2 other regulatory review programs. The CCO Form A program and DCBS are required to make their decisions concurrently. So when it is time for that process, the DCBS and Form A, CCO Form A decisions will be made at the same time. Next slide. To learn more about this, all of the public materials for the filing have been posted on our website. There is a link there to the transaction website. So that has the notice filing by the entities, as well as supporting documents that they have submitted. As we receive additional information during the course of our review, we will post that on the website as well as it becomes available. Next slide. One more. And so we invite the committee to provide a recommendation to the CCO Form A program regarding whether to approve with conditions, or disapprove the transaction. We would plan to seek a recommendation at a future committee meeting if invited to do so. We're currently, as I said, we're currently obtaining additional information, and we certainly want the committee to have the benefit of that information before making any recommendation. So this is why timing is a little bit uncertain, but we will, communicate with the committee and make sure when we receive information, additional information for consideration. We would also invite the committee, if you have any specific questions about the transaction that are best posed to the entities, that you can identify those for us. You can take those into consideration in our review and explore those questions with the entities. And those can be provided at any time. Next slide. We also welcome feedback from the public. The public can submit public comment. We have both an email address and a voicemail line where public comment can be left. We will also be holding a virtual public listening session sometime in the spring, where the public will have opportunity to provide comment, and additional information regarding that will be posted on our website once the date and time are available. And we also have a listserv, which I put the link to there,
where we'll send out updates when a public listening session gets scheduled. And next slide. I think that is all that I have for you today, but certainly welcome any questions from the committee. And thank you for letting us come in and speak to you about this.
Thank you, Erica. And we will be asking for volunteers to form a subcommittee to review the Form A more closely and develop a draft recommendation. The time commitment that we are expecting would be 1 to 2 1-hour meetings over the next 6 weeks to work with staff to draft a recommendation. So if you know right now that you are interested in joining that committee, please feel free to let us know. Otherwise, please, you can let us know during the discussion at the end or email Sarah and Tom afterwards. But otherwise, are there any questions right now for Erica? Lydia.
So we saw how big the Washington company is, but how many OHP members are served by Samaritan currently is sort of my thing. And then I have questions about like data transfer and security as well. But we'll start with like, how many people are we talking about here?
Yes, that is a great question. I don't want to misstate the membership numbers, so I can look those up and put them in the chat. So I have to give you an accurate answer as to the membership in a minute. And then I guess, yeah, you said you had data and security questions. I don't know if you want to elaborate on
I mean, it
that.
looks like I'm blanking on the one in Washington, Multicare or something. Looks like they're going to take over like the electronic health records and the billing and the data stuff. So like how to ensure the protection of that information and data, and like Oregon and Washington are fairly well aligned on sharing data with federal operations, but sort of what kind of guidelines or framework are going to be put in place so that Oregon laws are followed for Oregon members versus Washington laws.
Got it. Great. Yes, thank you for highlighting and flagging that issue. That's something that we'll take back and look into and consider in our review.
Thank you.
Thank you for those questions, Lydia. Other members? Okay, well, if we don't have any other questions right now, Erica, we will look forward to those numbers about the number of members that Samaritan serves, and appreciate you taking back the question about security for Oregon members. And we will take our break and reconvene at 10:35.
I'm ready when you're ready.
All right, well, now we have a presentation on what data sources are available to describe and study rates of uninsured Oregonians using the emergency department to help us build our understanding of available data. And we have a number of speakers: Piper Block from a research and data manager, Stephen Ranzoni, a hospital policy analyst from the hospital discharge team from OHA. Thank you, Piper and Stephen, for being here to present.
Hi, thank you. I think just really quick, I'll let Piper introduce herself, and then I will take it from there.
Hi everyone, I'm Piper Block, she, her pronouns. I'm the research and data manager in the Office of Health Analytics at OHA. So I manage the hospital reporting team as well as 2 other data related teams. and Stephen will be handling the presentation today.
All right, thank you, Piper. I'm Stephen Ranzoni. I'm Hospital Policy Advisor and Program Manager for Piper's team of the Hospital Reporting Program. Can I have the next slide, please? So yeah, we are the Hospital Reporting Program. Just as a little bit of where we are, we're over in OHA. We're in the Health Policy and Analytics Division, and what we do is we collect data, a variety of data on hospitals. We collect hospital financial data, utilization data. We have a community benefit report they send to us, some capital project expenditures when they do big builds, expand their hospital and things like that. We get a report. And what we do with all that data, primarily, our number one job is we respond to OHA leadership when they have questions. We respond to the legislature when they have questions, when a bill is impacting something. We do analysis, and then we also work with a number of research partners. And of course, we produce reports. We make public reports, we make dashboards, and we make the data available for the public, for the media, and for a variety of people to make use for that information for transparency. Next slide. So what we're talking about today that is of interest is our hospital discharge data sets. And so what that is information that is compiled out of a hospital's health records into their billing systems. It is the information that they are going to use to bill for a healthcare service. And so what that is it contains basically standard billing information. And so it has the diagnosis codes, it has the procedure codes, it has the dates of service and where it happens. What it doesn't have is basically specific clinical details. It doesn't have chart notes. It doesn't have like what the patient's blood pressure or weight was when they showed up, or some of those specific details, just the major key points of what the diagnosis was and what we did while we were there. We have this information for the two major settings for when you were an inpatient in the hospital, so when you were admitted to the hospital actually for treatment, or when you visited the emergency department. What is key, what's important to understand is we have this for everyone. And so this is the electronic health record system. It is going into their billing information. It has not been sent out yet. It is still from the hospital. And so this is everybody that entered the hospital, no matter who your payer is, no matter where you're from, if you're out of state, if you're out of country, it doesn't matter. If you are in that hospital, we have the data. Next slide, please. And really quick, we've been saying discharge for a while now, so let's explain that for a little bit. Discharge, admission, visit. I'm sure many of you have heard all these terms. An admission is, as the name implies, when a patient is formally registered into the hospital, when they are admitted to the hospital and that can be the ED, that can be the inpatient setting, that can also just be a clinical visit. You have been admitted into whatever it is that you are being treated for. A discharge, on the other hand, is when a patient has been formally released from care, when they've been released from the hospital, or when they have been released from the emergency department. That is how our program measures our units. That is how we measure the visits in these hospitals, right? And the reason for that is quite simple. That is the inclusion criteria to our data. So when we get this data from a vendor, we get routine updates. They're on a time period. It's a quarterly update. And so what is being included when we get that quarterly updates are records up to discharges that occur by a certain date. And so that will be information that will tell you that there are possibly records that are not showing up because they have been admitted yet, but not yet discharged by that date. So it's just a thing to keep in mind, a nuance of the data. And so part of that, all that is when you are using emergency room discharge data, it's important to understand that emergency room discharge only contains records of a person that was admitted into the emergency department and then discharged back out of it. It does not contain a record of a person that was visited the emergency room and then was admitted into the hospital as an inpatient. Those people are only contained in the inpatient data set. They are not found in the ED, in the emergency department data set. So as we go through and talk about emergency room rates and what is going on in the emergency room, it is only the universe of people that entered and exited the emergency department. It does not include people that were advanced up into inpatient care. So key to understand that. And just to clear up the final, a visit can mean anything. People often like to say visit, you visited the hospital, visited anything. Just know whenever you say visit, just always ask the person, what do you mean by visit? Because it could mean anything, right? Next slide, please. Really quick overview. There's 58 emergency departments in Oregon. We also include Unity Behavioral Health. That's a dedicated psychiatric ED. That's a it's housed at Legacy Manual, but it's a partnership of a couple hospitals that help operate that. Our ED volume varies quite significantly across the state, of course. So for our last fully completed year of data, that's 2024. Salem Hospital had the most ED discharges annually, over 86,000 of them. They averaged 236 discharges a day. Pioneer Memorial Hospital has our lowest volume. That's out there in Heppner in Eastern Oregon. They do a little over 1,000 annually, or about 3 visits per day. As of 2024, there was about 1.45 million discharges, a little over 1.5 million discharges. Of all that, just over 56,000 of them were uninsured patients. So that is what we're looking at. Next slide, please. In Oregon, we generally are doing a very good job of keeping the uninsurance rate low, right? This is data from our Oregon Health Insurance Survey, OHIS. And so going all the way back, we have done a great job of dropping the uninsurance rate in Oregon. We've done that through a number of policy interventions. Of course, the ACA expansion, the implementation of that back in 2015. And then through the policies through the pandemic, protracting or keeping redetermination out as long as we possibly could through the public health emergency. The Medicaid expansions through Healthcare Oregon, the basic health plan, all these have worked together in combination to keep the uninsurance rate in Oregon quite low. We are currently hovering down in below 5%, in and around 4%. And so bear in mind that that's where we're at. Rates are low. What those rates are going to do in the future is of course the question, right? Next slide. This screen has a picture. This is a screen capture of a dashboard. I'm going to show you all after this presentation. A wonderful dashboard we built that lets people just take a look at our discharge data and get some fun, quick information off of it. This just gives you a really quick overview of all the payers and the distribution of what makes up the emergency department discharge. Just the mix of it. Really quickly, I just want to point out 2025 is all the way on the right of these bars. That is year to date. We're only complete through the third quarter. That is why 2025 bars are so low. So move your eyes over to the left a little bit so you can see that the 2024 bars are more of what a complete year would look like. The information that you can quickly see, uninsured rates are all the way there to the right in the gray. In comparison in magnitude, of course, they are quite low compared to the other payers, but that is not an insignificant amount of people in Oregon. Again, that's 56,000 people are going to the emergency department that are uninsured. In terms of pure volume, Medicaid is the largest population that is continuing to use the ED by volume and by percentage. Next slide. Quick explanation of these charts. The y-axis is a percentage of all discharges. So I am speaking in terms of proportion right here. So since about 2018, the proportion of uninsured ED discharges, the percent of all discharges that they make up, has been dropping. So back in 2018, we're a little over 7% of all discharges were an uninsured patient. That has fallen through about 2023 and it's kind of flatlined out to a little under 4%, 3.7, 3.9. We're hanging out about there. That is the overall proportion of all discharges that are uninsured. blowing up those last 2 years to a quarterly trend. That is the chart that is on the right. You can see it's a stable. We are in a stable trend. You can see there's some seasonality to those quarters. Q4 tends to peak a little bit of emergency room use that generally coincides with flu and cold season. If you slap a trend line on there, as you can see with the dotted orange line, it's not really going anywhere. It's fairly stable. And that's been the story for the last 2+ years at a quarterly rate for the uninsured. Next slide. Getting into a little bit of the demographics of what is currently making up the uninsured discharges. This is first taking a look at age and patient gender. Really quick caveat: patient gender data in the discharge data is not SOGI compliant. It does not meet OHA's SOGI standards. The coding specifications are supposed to be patient preferred gender. We cannot attest to the accuracy of that at all, right? And so that is what it is supposed to be. That is all I can say about it. Whether or not it really is, we don't know. At any rate, patients that identify in the data as male and patients between the ages of 18 and 45 are the higher percentage of uninsured discharges compared to those that are insured. That's the bulk of what is making up that uninsured population by that demographic. You see I boxed them out here in orange. Oh, yeah, thank you, Sarah. Next slide, please. Just like we are not on the sexual orientation and gender identity compliant standard, our demographics for race, ethnicity, language, and disability, real D, are not compliant with the OHA standards. In fact, they are painfully behind the time. They are all the way back to the 1997 census data standards are what is reported into our data set. Kind of I guess you could say the colloquial layman term standard is the census 5 is what we get. The classic white, Asian, Black or African American, American Indian, and Native Hawaiian are the categories that are reported into the discharge data. And then Hispanic, Latino, or non-Hispanic Latino. At any rate, patients who identify as Hispanic or Latino have the highest percentage of uninsured discharges compared have the highest percentage compared with insured discharges. And those that also identify as others. There are, you can see as you go through these charts, there are other disparities. People that have reported an unknown. Black or African Americans also have a higher rate, but generally the largest disparity is what I am pointing out here, not all disparities. The largest is those that have other race, and those that identify Hispanic or Latino is the largest disparities reported here. Next slide, please. Generally speaking, there isn't a tremendous amount of difference in what is being utilized in the emergency department between the two populations. When you look at the uninsured and you look at the insured population, taking the insured as one large group, I realize that there's very different case mix between people that are on Medicare, for example, and people that are commercially insured. But if you just take insured as a large group and you just take uninsured as a large group, the top 4 chief complaints are all the same down the board. The most common reason a person is walking into the emergency department for both populations is other chest pain, unspecified chest pain. That is why people are walking in. Then you have nausea and upper respiratory infections. The first interesting difference that pops up is tooth abscesses. And I think that's one of your first ones that pop up that really speaks to a disparity likely due to a lack of insurance, a lack of being able to have dental coverage, or a lack of being able to access preventative care, and that's spilling into the emergency department. And And then you see again similar results though in different different slots, headache, unspecified headaches, syncope, that means fainting, are both showing up there. Another interesting one that possibly points to a lack of access to primary care is this upper epigastric pain. That refers to a number of very common primary care preventable conditions like gastritis, like acid reflux, like peptic ulcers or pancreatitis, that can generally can and should be treated in primary care settings. Outside of those, a couple of those key notable differences, I think that do speak to the disparities. Utilization is fairly similar down the board though. Next slide, please. That was a very brief overview of what that population looks like. Largely because to really dig into it, we need to scope out a study. And we can do that. The hospital reporting program, that is what we do. That's our reason for being. We do analytics. And so the hospital reporting program can support specific and detailed research and analytic requests. We can do readmission analysis. We can look for high utilization. We can look for those patterns and what is driving that and what's behind that. We can do specific analysis into what types of primary care preventable conditions are showing up in the emergency room. Are there higher rates among the uninsured versus the non-uninsured? We can look at rates of avoidable admissions. We can take closer looks at substance use and behavioral health related admissions and things like that. And we could do much more types of analysis beyond that. Those are the types of studies, research or whatnot that we need to scope out a study request, talk about, what it is exactly that we're looking at, have conversations, probably fill out, DUAs or types of study requests and have a more formal process behind it. But it's a conversation we can have, and we're very willing to do it. And so to have those conversations, you can obviously reach out to myself, you can reach out to Piper, or you can reach out to our program mailbox. And we're very happy to help support ongoing monitoring, analysis and research into uninsured utilization in the emergency department for sure. Sorry, DUA is a data use agreement. Our data is personally identified in the discharge data. It's a personal health information record. And so we take the confidentiality and the protection of the health data very seriously. And so we need to be careful about when we access this data, when we're using a person's personal health information and why we're using it. And even though, in even just the simple ability to go in and pull out some of these stats needs to be documented for the what and the why that we are doing it. And so so when we are doing analysis as such like that, many times we just need to have a documented reason. We need to have a study protocol in place so we can record the what, the why, and the reason that we accessed a person's personal health information and be able to report back as to why we did those things with that person's health information. I did see a couple questions pop up, but I didn't track them all.
I'm gonna jump in and
Would love to answer
sorry.
them.
Go ahead, Sarah.
Oh, probably what you were gonna do, Caroline. I'm for the sake of the both the presenter and the interpreters, can you clarify why the demographic data doesn't align with Real D standards?
Yes. This data is collected on a national standard that is mostly driven by CMS requirements. CMS unfortunately does not answer to us, and that's the bottom line. Is we cannot, as much as we would love to influence that decision making, we cannot direct or basically force a national standard to change. I think we can always attempt to try to push things in a direction, but what it would take is a lot of dedicated and very expensive and costly specific modification to all of our hospitals' electronic health records to accommodate the changes that need to happen. And so to be able to make that change happen into these billing systems that meet a national standard.
Thank you. You said that the discharge rates from the ED have stayed stable in the last 2 years. Do you know if the uninsured admission rates to the hospital have stayed, or inpatient discharge rates have stayed stable as well?
Yeah, and actually, we're going to go to after these questions, I'm going to show you a dashboard that can speak a little bit to that.
Okay, and we just have a few minutes left for
okay,
this presentation, so maybe let's jump to that.
we better do that.
Okay.
Am I capable of doing a screen share? I was told I
Sarah,
could.
are you able to answer that?
We can do that.
Yeah, Steven, you can do that.
Okay. Oh, there it is. Sorry. Share. I need to share. Are you all seeing a Google screen?
Yes.
Thank you. Any Google window, search Oregon Hospital Reporting Program. We should be the first Google search. This is our wonderful, wonderful hospital reporting program webpage and the site that you go to. Apologize if I'm being a little bit quick. Right here, as you scroll down, you'll see dashboards. We have several awesome dashboards I think everybody should check out. Hospital discharge dashboard is the one of interest. This is our landing page. This will provide information on both the inpatient and the emergency room settings. As you land on the landing page, you'll get the statewide trends. You're going to see inpatient trends. This goes back several years in time. So you can very quickly on the landing page, you can see what the inpatient setting is doing. You can see what the emergency department setting is doing. You'll be able to see the counts, and you'll be able to see average length of stay, which is also very much of interest. And I'm sorry, really quick, what's my cutoff time? Is it 11?
It is 11, yes.
Okay, so I'll just wrap this up really quickly saying there's a wonderful wealth of information that is on this dashboard, and I just showed you how to get to it. I would encourage people to go to it and explore it. I'm going to give a great shout out to our lead analyst, Lisa Wilson, who's on this call. She worked very hard in developing this dashboard. We made it as user-friendly as we possibly could. The information is straightforward, accessible, and you can find out a lot of interesting underlying details about the trends that are happening in the emergency department, the payer mix. I think I have enough time to quickly click over here to by payer. You can see the distribution of payer if you click over to emergency department. Sorry, a lot of information. It's loading. And this will be a quick way where you can quickly see what trends, this is that screen capture I showed you earlier, what trends are happening in that emergency department. I realize I can't get to where I was going to show you. Rates of people entering the emergency department advancing into inpatient stays have remained generally about the same as the rates of people going into the emergency department. That is, you would find that information here at the By ED Services tab. This is where we break down people who have utilized the emergency department services prior to becoming an inpatient. Here at the end, it's been about the same. It's a 50-50 breakdown of people that were in the ED before they were admitted, basically down the board. And over time, that rate has been fairly unchanged.
Thank you. That's really helpful. And this is a fantastic dashboard. Thank you very much for sharing it. And Sarah put it in the chat so that we can peruse at our leisure. This was a very informative presentation. Thank you so much for being here and your team being here. We really appreciate it. We are going to move on to public testimony. The Medicaid Advisory Committee welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual and is not a representation of the Medicaid Advisory Committee, its members, the Oregon Health Authority, or Oregon Department of Human Services. Each presenter is given 3 minutes to share. In the event that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we will start a 3-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the committee chairs and staff to determine the appropriate next steps. Committee staff will communicate the next steps with each public commenter. Sarah, do we have any public testimony today?
Yeah, we've had a request from Josh Leiden to give public testimony today.
Josh, are you here with us this morning?
I am. Can you guys hear me okay?
Yes, thank you. Thank you for being here.
Yeah,
And
thank you
you
guys for
to
go
begin
ahead.
your testimony.
Well, I have been putting things in the chat, but I'll introduce myself. My name is Josh Leiden. I'm the CEO of Stronger Oregon and a LCSW. We're one of the biggest mental health organizations in the state, in schools, outpatient, but also doing telehealth. One of the things that I put into the chat, I wanted to bring to your guys' attention because it's one of the priorities of the MAC committee, is the waiver program and the way that I interpret a memo sent by CMS to OHA. Basically, in my reading, especially the final paragraph stating that they're not going to renew any waivers, I think that is very important for this committee as well as for OHA to know about and actually address and move services over into billable codes under the primary funding mechanisms, especially for the substance abuse waiver, which is next month, and the mental health waiver in September 2027. I will paste it once more in case you don't like clicking links. You can Google that specific term and find that exact language. The other thing that I wanted to bring to the MAC committee, which I also emphasized in the chat, is parity. The Mental Health Parity and Addictions Equity Act specifically, and non-quantitative treatment limitations, or NQTLs. These are specific rules in consideration for healthcare, especially Medicaid, but it's all health insurance, that there is parity between mental health and substance abuse services to the medical profession in similar settings and or not. And it's basically, is there an analog? Is there a counterbalance? And so something that I've watched as part of your historical meetings and videos is you guys considering your committee considering associate mental health providers and kind of seeing them as somebody that should be parked under a COA. The very concept of a COA is only towards the mental health and substance abuse profession. There is no analog to doctors and physicians, and thus being a parity violation by definition, because it's also holding down peer support specialists in those settings when doctors can freely have them. There's numerous other parity violations that I welcome the committee to consider, including prevention services are allowed by physicians, but not by the mental health and the substance abuse profession unless grant funded. There's about 11 of them. I welcome giving a presentation so you guys can really hear and consider. I welcome the committee incorporating a parity consideration on every single action that you do, given that there's been so many things slipping through the cracks that don't actually take into consideration the NQTL component of parity, as well as the state rules, which are kind of a little bit watered down, but still have to adhere to Medicaid parity standards. This is emergency, and it's a tremendous liability to the state, as well as to every CCO that follows what the state says. Thank you for your time.
Thank you. Very much appreciate you being here and spending your time with us this morning. Do we have other members of the public to share testimony this morning? If not, then we will move forward to MAC discussion. So we have first on the agenda to vote to endorse the annual report. And has everyone had a chance to read the annual report? Any questions about that?
And for folks who may not recall, this is a reference back to presentation from last month about our annual letter and recommendations to OHA.
If there's no discussion about it, do I have a motion to endorse the annual report that was brought forward last month?
This is Hillary. I'll move a motion to endorse, excuse me.
Thank you, Hillary. Do I have a second?
This is Kelly, I'll second.
Thank you, Kelly. Any objections? Any abstentions? Okay, thank you. We will move forward with the annual report. Have a announcement of a standing reminder to complete your annual trainings, our annual trainings, I should say. Required by law, the discrimination and harassment and information privacy trainings in Workday. Contact Sarah or Tom for help. And next, we regretfully are announcing that this is Kelly DeVore's last meeting with us. Kelly has served as our coordinated care organization representative since November 2024. Kelly, do you have any words you'd like to share?
Thanks, Caroline. I just wanted to express appreciation for the staff and the rest of the MAC committee for the opportunity to serve alongside and learn with you all. Appreciate the chance and wish you all the best.
Thank you, Kelly. Do any members of the MAC have any words for Kelly?
You will be missed, Kelly. Very much. My camera's not working today. I'm not sure what's going on, but your verbiage, the way you frame things and every way that you present, you will be missed.
Thank you.
I absolutely agree, Kelly. I have learned a lot about CCO operations from you. So I very much appreciate the insights and teachings that you have brought us on this committee. So I thank you for being here the last year and few months and wish you well in your next steps and next roles. So thank you so much for sharing your time and wisdom with us.
I'll just say here. I am of course sorry to see you go, but hopefully we'll continue to see you around.
As a next announcement, we have several names for new members of the MAC with the governor's office for consideration, and we should be hearing in early March. The next announcement, Sarah, I'm going to have to ask you for clarification. A survey going to you in your email right now. Can you clarify that survey information?
Yes, sorry for the scant notes there, but we staff want to understand better if we are how these meetings are going for you all and what specific ways we can improve them. I know we do kind of a little exercise at the end of every meeting, but this is going to be a little bit deeper dive into how well meetings are meeting your needs. So we're going to put that in your email shortly, and I'm just asking for folks to look for that. Thanks so much.
Thank you, Sarah. Always nice to have an opportunity to try to amend and improve, and in a continual spirit of process improvement. And I'm going to circle back to the request brought up earlier. Any excited volunteers to serve on a Form A subcommittee on the proposed merger of IHN and of Samaritan and Multi-Care? And again, if no takers right now, Sarah, you can email Sarah and Tom later, and Sarah will also request volunteers at a future date. And again, this is requesting time commitment of 1 to 2 meetings of 1 hour each over the next 6 weeks. And as nobody is leaping to raise their hand, I will move forward. Are there any other items of MAC business or MAC members who would like to speak at this time? Additional discussion, basically opening the floor to MAC members. Any discussion about any of the presentations we saw today? Okay. So now I think we will wrap up, and I'll turn over the meeting to Sarah to close us out. Thank you everyone for being here.
Thanks, everybody. Well, again, we are going to send out survey to all of you. And if there are any quick thoughts that folks want to share now in the spirit of continuous improvement, any roses, things that you enjoyed about the meeting today, any thorns, anything that felt a little pokey, and any buds, things that you want to be sure to nurture for the future, now would be the time.
I appreciated the robust discussion about the policy rubric, and I really enjoyed learning more about the ED admission discharge. I was a little surprised by some of that data, so it was appreciated having that presentation.
I'll jump in. I was trying to type this, but I can say it quicker. I would just say that I appreciated that some of the larger agenda items today had more time allocated to them. It did not feel as rushed as some other previous discussions.
Okay. Any other MAC members with comments here?
Thank you. I appreciated the willingness to answer questions, and now I just joined, so a lot of the context is missing for me. So I appreciate both filling in on that. I appreciated the ED data as well. Some of the data was definitely surprising. The abscess part was not that we didn't know, but perspective. So I appreciate the conversations.
Great. I'm going to take staff privilege to say that I really like having new voices asking questions, because I think sometimes we forget that members of, if there's stuff that we don't know, like members of the public don't know, right? Like, so those questions are really valuable. I just want to encourage MAC members to keep asking questions, even if it feels like it's something you should know. Because if you don't know it, you can be sure that folks who are watching today don't know it either.
And I was going to add, just really happy to answer any questions new members have. So thank you for speaking up and asking them. Really happy to have you here.
Okay, I see Kaya's hand up and then Lydia's. Kaya?
I was just going to ask if there is a way when we do have questions like we did in the beginning of the meeting. I just felt like it was a little bit challenging, and I felt kind of bad for some folks that needed to answer promptly. So I wanted to see if it is available, like can we ask those questions before, or because it felt like somebody got put on the spot. Um, and felt like it was almost challenging, but that was just the way that I was uh perceiving it. And so if we could hash those out maybe before, especially if it's somebody from the MAC, if we could maybe answer some of those before the meeting, or just so it doesn't feel so challenging and put somebody right on the spot of like, geez, maybe we didn't do this great, or maybe that wasn't well, because that's the feeling that I was getting from it until Caroline was able to answer some of them.
Thanks for that. Take that back. I know that one of my goals, like one of my, work goals, is to do a better job of in advance fleshing out what kinds of questions we can expect to come up. So, we'll continue to work on that. Appreciate that feedback.
Thank you.
Okay, Lydia.
I really appreciated how careful everyone was to get the acronyms into the chat, because it really, and I use closed captioning, and ocean came out as ocean, and yeah, so I appreciate people working to bring clarity to all of the jargon that everybody uses.
Thanks for sharing that.
And the
All right.
10-minute break was helpful. Sorry.
That's great. Well, speaking of 10-minute breaks, we are way ahead. So, unless there's less call for further comments today. Okay, with that, I'll just say thank you all. Really appreciate everybody's participation today. We will meet, we'll meet again online on Wednesday, April 29th at 9:05 a.m. And we'll see you then. Thanks
All
so
right,
much.
thank you.
Bye.